is hepatic encephalopathy? What's the pathophysiology? Well, we don't know completely, but what we do know is there's the gut microbiome, which, as you know, we have more gut microbiome than we do cells in our body, okay? And this is associated with liver disease and HE. So you get a dysbiosis, meaning there's always good bacteria and bad bacteria. As you all know also, on the previous talk when we were talking about C. diff and checking that, we all have C. diff inside of us. It's just our good bacteria is controlling the C. diff. And then when you take too much antibiotics or whatever, or you get sick, the bad bacteria take over, which then it makes C. diff more prominent. So what about now in HE? There's a lot of different bacteria that we're not going to go into. That's besides the point of this lecture. But what you guys just did, you ate protein, right? If you did have liver disease, or actually even if you don't have liver disease, anything you eat that has protein gets broken down by the gut microbiome. And you go through that whole pathway with urea cycle and through the liver. And there's byproducts. The toxins are ammonia. Ammonia is one of the toxins. But when you have liver disease and cirrhosis, you cannot break down that ammonia. That's one of the pathophysiologic mechanisms. And ammonia is labeled NH3 in this diagram here that my colleague and I have shown in prior studies. So when you can't break that down, then ammonia kind of seeps into the bloodstream and then it goes into the brain. Now the brain, they have astrocytes. Astrocytes, it basically is not able to process this toxin, and you get this osmotic inflammation and swelling. And as you know, look, we have our skull. We can't, our skull is hard. You can't, when you have expansion, either two things will happen. If the ammonia is really, really high, you herniate, and these people can die, okay? Or, you know, you get a little confusion. When you get a little brain swelling, you get a little confusion. So the ammonia crosses the blood-brain barrier, and this is how you do it. Now, glutamine accumulation causes the cerebral dysfunction. So what are the characteristics associated with poor outcomes following a diagnosis of HE? So usually a little elderly males, people with end-stage renal disease, depending on death versus hospital, disease race does sometimes matter in this sense. The etiologies in general, because a lot of the studies were done in the past where it was mostly alcohol and Hep C, remember we can cure Hep C now, this is what has been statistically associated with worsening outcomes. And what are the characteristics associated with poor outcomes following a diagnosis of HE? If you look at gastroenterology consults, people on rifaximin, ascites, varices, and TIPS, these are all complications of cirrhosis or portal hypertension. You could see that there is definitely significant differences between the two groups. And there's a Charlson comorbidity index, meaning the sicker you are, the more organs that are doing poorly, the worse you do. So what about the CMS announcing this first ICD-10 code for HE? I was very happy. We were on a conference call where I was told that this code was changing, I think one day before it happened. And this is very important because this helps with billing, number one. Number two, it helps with patient and actually getting rifaximin, which is a second-line therapy. We'll talk about that after lactulose failure. Because what happens, you won't believe, in our clinic, we get so many denials. Because what happened in the past, they had it poorly coded. The ICD-10 was, they grouped it into cirrhosis. And it's like, well, there's lots of other causes for cirrhosis. Hepatic encephalopathy now has this new coding, K76.82. Insurance then will look at that. You can get reimbursements. We can write and treat our patients and write for rifaximin for better patient care and less readmissions. Now, what is the multi-layer impact of HE? If you really think about it, it takes a village, right? So if you look at liver dysfunction and portal hypertension, the microbiome, altered genetics, there are genetic factors that have been looked at, and they do show some different haplotypes in the genes on why some people get more HE than others. Because you might have some cirrhotics that you see, and you're like, well, this person doesn't come into the hospital, but this other person does. There's genetic factors for sure. Renal dysfunction, obviously there's gut barrier for immunity, and skeletal muscle. A lot of you have seen these patients that have a protuberant belly. They might have ascites due to portal hypertension, very thin muscles. Cirrhosis is a catabolic state. It breaks down muscles. You basically lose protein. That's why we recommend protein intake, and we'll have a slide on that later. Now, this leads to, obviously, if patients come into the hospital, Their loved ones have to bring them in or stay with them, lost wages, right? Losing time, quality of life, readmissions. It becomes very difficult on their caregivers. And then if you look at family and caregiver and physical therapy issues, if these patients, the final goal is liver transplant, because that's the end-all be-all fix for these patients, they really have to show that they have strength in order to achieve getting to that liver transplant. So a lot of these people are frail. These people lose muscle, right? So nutrition becomes very important. They get readmitted, and it becomes very, very difficult for them. So what about HE in the hospital setting? The trends are going up, okay, in the U.S. And you can see in this graph from 2010 to 2014, number of hospitalization and incidence of HE in the red line. You can see that the rates have definitely gone up, and we have newer data that show also rates are still going up. I think it's underreported because when someone comes in for, let's say, hepatic encephalopathy confusion, usually the first 1, 2, or 3 diagnosis is liver failure, esophageal variceal bleeding, let's say. The patient's confused and they wouldn't really put, or kidney failure, okay? So that can be or underreported. But the total hospitalization, a quarter of the have gone up. As you can see, prolonged hospitalization 38% and in-hospital mortality 45%. Now, what are the factors associated with greater risk of HE? And Dr. Tapper, who wrote this, shows that portal hypertension, which is pressure from the liver. Portal means, there's a portal vein that comes into the liver. Hypertension is high blood pressure, but portal hypertension, high pressure in the liver, that causes a backflow, okay? So blood's flowing from your heart to your brain, going all the way down your legs, coming through the liver and coming back to your heart. So it's a closed system. When you have cirrhosis, you get that extra pressure, like 98, 99% of the blood's flowing back to your heart, but there's maybe 1% or so flowing backwards. That's the portal hypertension. It causes the ascites, the protuberant belly, the varices, and the hepatic encephalopathy. Now, that showed adjusted a hazard ratio of 3.4 times higher when you have portal hypertension versus without. Now, when you look at cause of cirrhosis, if you looked at it, the alcoholics versus the non-alcoholics had a higher degree of increased risk. And the reason is that also causes portal hypertension. When you drink alcohol, that goes into the system and it causes increased pressure in the liver, so that releases those toxins. We talked about one part is ammonia, and that causes confusion of the brain. What about medication use? A lot of our patients, they do take benzodiazepine, GABAergics, opioids, and this causes confusion when you have cirrhosis. And the reason is this: it's hard to clear out. Every medicine, when you have to go through FDA panel, it gets cleared by the kidney and liver. But if it fails the test of being safe for the liver, it gets banned. You never see that on markets. Now, PPIs, they looked at this study. As you know, it's sometimes very overprescribed. It does have an association because you kill the gut bacteria. So what happens is patients come in, they're on a PPI, you just continue their medicine. The hepatologists really need to start asking, why are you on this? Were you on it because you had some esophagitis, some reflux, and then discontinue the medicine? Because if they continue it on for a long time, guess what? That's decreasing the acid in the stomach. When it decreases the acid, guess what with the bacteria that's there? You don't have the good and bacteria fighting each other, right? So then they get more HE because remember, it's dysbiosis and bacterial problems. 30-day readmission is associated with poor survival in hospitalized patients with HE. So on this study, when you look at patients readmitted within 30 days, they do worse overall. So in general, they have a 4-time more likelihood of doing poorly within the first 30 days, okay? So you might ask, well, then how do we make sure they don't get readmitted? And we'll talk about that, but a spoiler alert will be if they failed lactulose, remember you want to add rifaximin as the FDA-approved medicine to their regimen to decrease readmission, and we'll show a graph that they decrease readmission by 50%. What are the factors contributing to HE readmission? Well, failure to fill prescriptions. Now with the new ICD-10 code, that will be good because a lot of the times the insurance would kick it back and say this is not the indication for it. There's some other indications for rifaximin. We're not talking about that. But lack of follow-up. So when they get discharged, it's very important that they see their GI doctor or hepatologists. It'll be very hard to get into primary care. So at least at Baylor, the way we do it is we try to get them in within 1 week or 2 weeks because, number one, they might not be able to fill their prescription. They might not know how to titrate the lactulose or additive rifaximin. And then we're there to help support them and get that appeal process started so then they can get on that medicine. There can be other comorbidities that lead to HE readmission. So how do you recognize and diagnose HE? Well, there's 3 types, and this is not really important for this discussion, but there's acute liver failure that can cause HE. There is portosystemic shunts or bypass that we talked about. Our colleagues, our interventional radiology college, when we call on them to, let's say someone's have esophageal variceal bleed, we go in and we do endoscopy, we put rubber bands, stop the varices, but they keep rebleeding. There was a New England Journal article saying early tips, which is the transjugular intrahepatic portosystemic shunt, where they put in a shunt through the liver, is life-saving if you can't stop the bleeding. So when you have a shunt, remember, more blood will flow that way, backwards, and they can get more HE. Or they have it naturally. So the portosystemic bypass, portosystemic shunt, they just form these natural shunts that cause them to have higher HE. And then cirrhosis. So this is the main topic for type C, where we talk about cirrhosis. So this is the West Haven criteria for minimal grade 1 HE. So these are your outpatients in general. Minimal, they changed the name. This is kind of the whole area. Minimal in grade 1 is covert HE, and then grade 2, 3, and 4 are overt HE. Overt means you're hospitalized. It's acute. This could be a little chronic, meaning you can't really tell. When they're outpatient, they might be a little slow to speak. Some of the times they get frustrated easy with their loved one. There's more arguments. Now, granted, with COVID, they're in the house a lot together. I don't know, maybe they're arguing more. I don't know. That's maybe a separate situation. But the other thing is I think about with these patients is like, if you stay up, like, look, I can't stay up past 11 nowadays. And if I wake up or I get a bad night of sleep, you're grouchy, right? You're a little tired. You're maybe a little slow until you get your coffee in the morning. It's kind of this lack of awareness, kind of a little tiredness. That's what you talk about minimal or grade 1. Of course, I don't have liver disease, but just that's the example I'm giving. So think about it for that. Now, the West Haven criteria, this is the gold standard of how we diagnose grade 2, 3, and 4. 4 is easy, coma. They come in, sternal rub, you can't wake them up. 2 and 3 are hard because patients can have asterixis, which is the physical exam that we do. So you tell them to hold out your hands, elbows straight, and spread out their fingers, and they'll have a flap. This is called asterixis, okay? And so when they do this, I mean, renal failure can do that too, uremia, but they have this flap. In grade 2, you see it. Grade 3 sometimes, but if they're kind of going close to grade 4, you don't see that. But what about the description? They definitely have inappropriate behavior for grade 2. They make some errors of 3 or more of the following: day of the month or week or year, but they know where they are, like their city, or they're aware of their space. That is grade 3. If they don't know where they are, like city, where are you from, or what hospital is this, then that is more grade 3. They're a little more sleepy. You're at the point where you're talking to them, they might fall asleep on exam. They're very slow to speak. But the one that separates is time and space for grade 2 versus grade 3. So this is the overall diagram when we went over those past 2 slides, showing covert and overt. The green ones, grade 2, 3, and 4, are the ones that are acute or overt encephalopathy and are in the hospital. Now, how do you diagnose and stage HE? Well, it's based on a clinical diagnosis, so this is really important. There are reliable markers like disorientation and asterixis. It's a clinical diagnosis. You don't need ammonia levels. Remember, there's multiple pathophysiologic mechanisms. Ammonia is one of them, but you don't need ammonia to make the diagnosis. Actually, there's been some studies showing that ammonia levels can be misrepresented, misinterpreted. I'll give you a kind of fun fact. Ammonia levels can be falsely elevated. There's about 7 different causes. My 2 favorite, maybe 3. One is back in the day when the techs would smoke, and now most hospitals are non-smoking. By the time they draw the labs and the smoke diffuses through the test tube and causes false elevation pneumonia. So that's one fun fact. Excessive tourniquet and not putting it on ice and running it within 15 minutes, false elevation. So that's why you can see ammonia can be falsely elevated. It doesn't mean they don't have HE, but it's a clinical diagnosis. You go talk to the patient, see if they're confused, see if they have asterixis, and then that's that clinical diagnosis. They can also have slowness, psychomotor slowing, attention deficits. The West Haven criteria, which we went over, is sort of the gold standard. And then there's quantitative testing, which I've done with my team for research purposes. What precipitates these patients? Well, some of it is our fault, meaning healthcare providers like hepatologists or GI doctors, where if someone has ascites, we give them medicines to help that, to get rid of the fluid. Well, that can lead to dehydration, right? Or acute renal failure. Or if we do paracentesis at our outpatient clinic, if we don't follow them closely, we can also put them in renal failure, right? So that's something that can be part of the acute renal failure. So you can see 3/4 of it is due to that. Lactulose non-adherence. I mean, 50% or so do not want to take it. I mean, let me ask you this. Would you want to take a medicine to have 3 bowel movements a day? I mean, it's already difficult to go once, right? So if you go twice or 3 times, this is just such a hassle, right? So a lot of these patients, you're supposed to titrate to 2 to 4 bowel movements a day, and some of them don't want to do that. They think they're fine because they're mentally fine, right? They have 1 bowel movement, 2, and they're like, I'm fine. What happens, it starts building up. That ammonia that we talked about, even though it's not important to diagnose it, it's one of the pathophysiologic mechanisms. Also, we don't know what they eat at home, right? They might change their diet, and so that changes the gut bacteria. So the lactose non-adherence also is related to what I like to call is constipation. If they don't take it, they're going to be more constipated, right? Or relative constipation. They might have 1 bowel movement a day. They're not having bowel movements to get rid of the ammonia because that's the only way currently that it can come out. They can be on opioids, benzodiazepine, which can cause, 1/4 of them get the precipitating factor hypokalemia, because what happens is with ammonia, the hypokalemia causes acid-base disturbance, and then ammonia, the positive charge, cannot become ammonium. So when you don't have a positive charge on ammonia, then it crosses the blood-brain barrier, and then you get confusion. Tips we talked about, remember, GI bleeding, hyponatremia, low sodium, obviously. This is about 10% or so. And then large volume paracentesis, which here is 9%, but it can also lead to acute renal failure. High protein diet and has nothing to do with this. In the past, when I was training at UVA, the thought was if you have too much of high protein, the protein gets broken down by the gut microbiome, and then it causes a byproduct ammonia, and then it causes more confusion. Well, that's not it. They've disproved that. They actually need protein. So what diagnostic tests do you need? You guys are all very good at this, obviously checking CBC, comprehensive metabolic panel. But the important thing is anyone that comes in with confusion and has cirrhosis or HE, they need to be worked up for infection. Infection is the #1 cause of really the precipitants. So you want to get blood cultures, UA, chest x-rays, paracentesis, because they can have what's called spontaneous bacterial peritonitis. And then alcohol or drug screen if you're suspicious. What are the differential diagnoses? Well, some of you maybe last night you overdrank. Well, if you don't have liver disease and you're intoxicated, you might act like you're a little confused and have hepatic encephalopathy, but you don't have liver disease, so we can't call it that. It's just drugs, alcohol, intoxication. Now, electrolyte. If any of us in this room had a low sodium or low potassium, we would feel a little confused. We would say something's not right, and then you go to the urgent care or ER, and then they check, and you're like, oh, my sodium's low, right? So that's one of the differential diagnoses. You can have seizure disorder or neuropsych disorders, which become important. Obviously, in these patients, they're at high risk for falls, so they can have bleeding. They usually don't have strokes, although fatty liver disease, which has now progressed over time, they lead to coronary artery disease. That leads to strokes and heart attacks. Other presentations, dementia, brain lesions, or obstructive sleep apnea. And you might ask, well, what? That doesn't make sense. Well, if they have OSA, then what's happening is they're changing their metabolic and respiratory acidosis and alkalosis, right? So then that goes back to that positive charge that I was talking about for ammonia and ammonium. So treatment. It's a four-pronged approach. Our liver society, which is the ASLD, we just had the meeting last week in Washington, D.C., and EASL, which is the European Society, looks at it from providing support for the unconscious patient, because you don't want them to herniate, right, and die. You find and treat alternative causes. All those things we talked about, the precipitants, you want to treat that while you're attacking and treating hepatic encephalopathy with lactulose, and then additive therapy, rifaximin, once they've failed lactulose therapy. And then that's where you go through this algorithm. We were in Virginia to come up with the Ishan conference, my colleague, Dr. Bajaj, and we came up with liver cirrhosis and altered mentation. What do you need to do? Well, there's ABCs, the airway, breathing, and circulation. Obviously, if they have a GCS less than 8, these patients need to go to the ICU, need to be intubated, and that's fine. You can deal with the confusional part later because they can't breathe. And so airway is always important. Circulation, when you look at that, you want to make sure that they're not bleeding. Acute episodes of overt HE, obviously you want to admit them to the hospital, and you'll determine if they're sick enough to go to the ICU or not. And you want to exclude all these other causes that we talked about. Electrolytes, you want to make sure their sodium is not too low, and you don't want to raise it too fast. Their potassium is not too low. They're not in renal failure. Some of these patients, they just have renal failure. And then what happens is that precipitates their hepatic encephalopathy. You give them IV fluids, you treat them with current therapies, lactulose, and if they are already on rifaximin, you give them that. And then they get better. It might be a 1 or 2 day stay. If they have bleeding, obviously, you would get repeat CT scans, make sure that things aren't progressing, maybe call your neurosurgical colleagues. Benzodiazepines, they are problematic. A lot of our patients, sometimes if they're alcoholics, they're trying to quit alcohol, and it's very difficult. The COVID has not made it better. So what happens is it works on GABA receptors. Well, same with benzodiazepine, they work on GABA. So when someone comes in with either alcohol withdrawal, you give them benzodiazepines to get them out of that withdrawal state, and that's fine. But if they get on it because of chronic anxiety, or they feel like they're going to be on it for a long time because of alcohol, well, that's not good because they can come in actually confused. So the treatment here, you want to treat the precipitating factors. So remember, if they are bleeding, we do the scopes. If they have infections, you give them antibiotics up front, wait until all the infection panels come back, and if they're negative, then you can pull them off antibiotics. If they have constipation or relative constipation, when you talk to the patient, you'll find out they might be non-compliant with their lactose. Maybe all you need to do, and sometimes the ER does this, they give them a couple doses of lactose and they wake up because they're kind of in that grade 2, and then they have a couple bowel movements in the ER and then they go home because they just didn't take their lactose. You want to make sure if they're obviously getting alcohol, you want to replace thiamine. And nutritional support becomes important because remember I told you it's a catabolic state. These patients are breaking down muscle, and so they actually need protein to help them. So lactulose is the current therapy, and the additional therapy, if there's no response in 24 hours, you want to add rifaximin. That's usually the case after they've failed lactulose therapy, right? So you don't. The current FDA label is not to add it on their first admission. It's after they've failed and come back in. Now we will talk about these other therapies, PEG and LOLA, in a second, and the PEG is off-label, just so you know. So the non-absorbable disaccharides, which is lactulose, it promotes ammonia, converts it to ammonium in the colon, shifting the bacteria to urease and non-urease producing bacteria, and you get a cathartic effect. And what happens is you basically have bowel movements to get rid of the ammonia. Rifaximin reduces ammonia by eliminating ammonia-producing colon bacteria, and it reduces the risk of overt HE. And so remember, it also changes the gut microbiome, but it's a non-absorbable antibiotic. Remember, a lot of these patients have infections. There was one study by Sharma, which I'll show, that had patients that actually got rifaximin in the ICU. Again, off-label, it was done in India. That wasn't the indication, but they showed that in the sick patient population, those patients did better. Zinc also enhances urea formation, but the problem is if you check a zinc level, it'll take a week to come back. You won't even know if they're zinc deficient. Most of them are. Now, some of these therapies off-label use is PEG 3350 electrolyte solution. It's basically the brand name, so you know, is Go Lightly or Miralax, but we're going to call it PEG 3350. That is a cathartic, right? You have them have bowel movements, then they get rid of the ammonia, they wake up. Ornithine phenylacetate, we did this study. It was in phase 2B. It did show, obviously, improvement, but it's not ready for prime time yet. So these are emergent therapies, off-label use at this time. Lactulose for reduction in ammonia with overt HE. So what's the dose? You give them 30 mils orally 3 times a day. Now, this is the hard part because that's the standard. But the problem is, as some of you might know, maybe someone takes 1 or 2 of those doses and they already have 3 bowel movements. Well, then they don't need the 3rd dose. So part of our job is to counsel them and tell them, look, it's a titratable medicine. It's not like a blood pressure medicine where you have to either take it once or twice a day, depending which medicine is prescribed. This is a titratable medicine. If you've taken 1 dose and you've already had 3 bowel movements in the morning, you don't need your 2nd or 3rd dose. Now, the caveat there is, with these bowel movements, you have to know what's really a bowel movement, right? Everyone here might have a different bowel movement. You might have those pebbles, you might have the big ones, all that stuff, right? So, but you have to ask your patients. A lot of them, when I have the fellows and residents, they've had 6 bowel movements. Well, what do you mean 6? Is that diarrhea? Is it not? And then you go talk to the patient and you just say, well, let me get a drink first before I was going to say, how much do you fill up this cup when you have 1 bowel movement? What do you mean my 6 bowel movements didn't even fill up half of it? Well, then that's not a bowel movement. So it's all relative, right? But part of it is like common sense. You have to ask them, that 6 bowel movements wouldn't even have. So they're even half a bowel movement. So that's why it's important to titrate these medicines. Now, what if they're in the ICU and they're sick? They're maybe intubated. Well, you can give it rectally. The nurses don't like you for that. But you 300 mils and 700 mils of water of lactulose, enema-wise, and you give it, every 30 to 60 minutes. You give it in 30 to 60 minutes. Most of it comes out, and you titrate that until the patients get a little better. Now, the problem is if they're sedated, it's going to be hard to get them out of hepatic encephalopathy. You still want to give them rectal lactulose, but they might be intubated for a number of other causes, right? So it might take them a couple days to wake up, but you're still doing your job on your part to try to treat their confusional states, even though they're sedated, because the sedation also causes them to be confused, and you don't know how they're doing. Adverse events, well, there's aspiration, dehydration, hypernatremia. If these patients take a lot of the lactulose, you can imagine you dehydrate them, then the sodium goes up, right? So you don't want to, that's why we tell them to titrate 3 to 5 bowel movements. Obviously, perianal skin irritation, if you're having a lot of bowel movements, it's irritating. And then it can actually worsen HE if you get too much of it. We rarely have a problem with that. Now, this was the study I was telling you about, Bass et al. Colleagues, where they looked at New England Journal in 2010 and survival benefit of rifaximin as added on to lactulose for treatment of acute overt HE. And 91% of these patients in this study were on concomitant lactulose therapy. So when they looked at this, you can see there's a better survival and decreased hospital readmission. The blue is the rifaximin on the second graph there versus placebo in gray. And these incidents of common AEs did not differ significantly between the 2 groups. But usually this really helped. This was the pivotal study that actually put rifaximin on the map, saying it decreases hospital readmission. This study that we performed, PEG 3350, again, off-label use. We compared patients that came into the hospital at all grades of encephalopathy and did not give them lactulose. We gave them PEG, but it was a proof of concept study to have a whole gallon or 4 liters to make sure that they would wake up. And with this HELP trial, the rate of HE resolution decreased by 50%. We used this HESA paper pencil form test. It took about 20 minutes to rank the patients based on clinical findings, as well as this paper pencil test to determine what grade they were. And it was validated across all grades of encephalopathy. And that definitely improved by greater than or equal to 1 grade within 24 hours. We did put them back on their lactose after that 24-hour period. We just wanted a proof of study. And the HESA improved much better Length of stay in our study did not, it was trending towards significance. And then the study has been reperformed 3 other times, and they all showed the same benefit. Again, off-label use, but length of stay in all those 3 other studies were improved, okay? So on average, the hospitalization went from 3 to 2 days for PEG. Ornithine phenolphthaleate, we also did this study, phase 2B, and published it. And this whole pathway of urea and glutamine, ornithine phenolphthaleate binds ammonia, and you excrete the ammonia in the kidneys as a different mechanism of action. But this, again, this is not ready for prime time. The phase 3 study is going to come, hopefully. But in this study, it showed a decrease in time when you took out the 31 patients, so from chart A to chart B, the 31 patients that did not have high ammonia levels. This is an ammonia scavenger. It binds ammonia and you urinate out ammonia, okay? When you took out those 31 patients that after you sent the central ammonia lab, by the time they got it back, you had to put them in the trial anyways, they found out, oh, this ammonia didn't qualify them, but they were already in the trial. Then it showed a statistical significant difference. So just know that there's a potential future mechanism of action, which would be great if it happens, but we have to wait for more research and a phase 3 study to see if it's actually important. So what are the indications for HE prophylaxis? Now we're going to look at the Europeans and we're going to look at the United States. So the EASL guidelines and the AASLD guidelines. So lactose is recommended as a secondary prophylaxis following the first episode of overt HE and should be titrated to 2 to 3 bowel movements. And that is a strong recommendation based on European guidelines, 96% consensus. Rifaximin as an adjunct to lactulose is recommended as a secondary prophylaxis following greater than or 1 additional episodes of overt HE within 6 months of the first. So what that means is they came to the hospital, patient A, you gave them lactose, you treated their underlying HE, sent out to come see me or my colleagues. You still tell them, hey, you need to take lactulose, you need to have 2 to 3 bowel movements, and then they get readmitted, okay? Well, that's the time that you prescribe rifaximin because they failed lactose therapy. It's their readmission for overt HE, and then you want to do that within 6 months of their first one. So the ASL and the EASL guidelines for 2014, which were older, was lactose recommended for prevention, and rifaximin as add-on to lactose to prevent overt HE. Now, what about this study was also done by Sharma. This was not the one I was talking about earlier, and you could never do this in the US. They looked at placebo versus lactulose, and patients that came in, well, did lactulose actually prevent HE versus those that didn't? So basically, you gave patients placebo, and almost 50% did not get better, obviously, and then lactulose, 20% had HE episodes, okay? So it showed that lactulose was obviously working better than placebo. What about the effects of rifaximin on breakthrough HE episodes and HE-related hospitalization? Well, the breakthrough episodes, if you look at the gray versus the blue, the placebo is in the gray versus rifaximin in the blue. You see a 50% reduction in breakthrough episodes of HE and 40% HE-related hospitalization over a 6-month period compared to placebo. So it works, and you get decreased readmissions. What about long-term maintenance for rifaximin? Well, if you look at placebo all the way in the left in gray and you shift it with the light blue and go all the way to the right, you could see that patients on all rifaximin had decreased HE-related hospitalizations and all-cause hospitalizations over a 2-year period. What about transition of care following acute overt HE? Well, you want to plan for the patient discharge with their neurologic status, patient and caregiver education, because they're the ones that are going to be knowing if the patient is doing okay. If you have your loved one and they think they're fine, it's usually the caregiver that knows if they're confused. The patient themselves doesn't know. They don't know that they're confused. And you want to have post-discharge follow-up. And all these points you guys know, you want to identify the risk factors and the precipitants and treat those. You want to avoid those precipitants. You also want to avoid certain medicines that the patient might be on. Say, hey, look, this is what's causing the issue. I had one patient that was on chronic narcotics. Narcotics, is overprescribed also. And they had chronic pain. You have to figure out what the chronic pain is. If you get narcotics, of course, it's suppressing the pain. But what is the pain? You have to figure that out. Once you figure that out, they don't need pain medicine anymore. Once we took them off their pain medicine, they didn't have HE anymore because that caused the cascade. So precipitants of HE in patients with cirrhosis, we talked about dehydration. About 50% to 75% get that, or acute kidney injury, a third to about 3/4 of patients. Lactose non-adherence, about 50% of the patients. And then constipation, which is sort of in line with lactose non-adherence, although they're a little separate, 40%. Infection, 20 to 42%, were the most frequent identified precipitants in these hospitalized patients. So really infection is important, just know that, and electrolyte imbalances. And you would obviously want to do a complete workup before you treat their underlying precipitant to see what they had. So what about nutrition? Okay, this is part, for these patients, they need 1.2 to 1.5 grams per kilogram protein intake. That becomes important. So think about a 70 kilogram male or female. They would need more than 70 grams of protein. That's really hard to do, guys. If you think about it, most of you probably don't even need 50 grams a day. But these cirrhotics, they really need to have protein because they break down protein. And when they break down protein, what you see the protuberant belly and skinny arms and legs because they're breaking down muscle. Also, muscle can sort of absorb ammonia. So if you bulk them up by telling them to drink protein shakes and get them educated on nutrition, that helps. Sarcopenia is one of those things that they lose the muscle fibers, and the muscle health becomes very, very important. Okay, it's this vicious cycle. And then the target is 35 kcals per kilogram per day calorie intake for the non-obese, and you want to avoid periods of fasting. Now the problem is they come into our hospital. These patients, they end up being MPO for whatever procedure. So we're not doing them a favor. They're actually getting a disservice. We're making them MPO. And we say avoid periods of fasting. Well, then what happens is they can't get the procedure that they need, right? So they're even more in a calorie deficit and they're more in a protein deficit. So just be aware of that, okay? Now what about driving? This is actually an interesting topic. Bajaz, my colleague, looked at this a lot in Virginia. And the influence of driving with prior overt HE, minimal HE, patients on different medicines that can cause confusion depending on their age, their driving experience. And what were the consequences? He had a area where once he had patients actually go out on the road, but most of it was simulation because he was scared they were going to kill him. Driving around with cones and stuff. It was very scary. So he did a lot of simulations, and they had more accidents, near misses, and what's called getting lost. So like the simulation would say, okay, there's a voice in the background saying, at the next stop sign, turn right, and then they pull up in a simulation and they turn left. Or when you see the store front on the right side, I want you to pull into the parking lot, and they would just pass it. So they would miss a lot of these, okay? Then they had, so what happened was it led to this driving assessment and what the role of the physician is. Well, we didn't go into law for one or another reason, but we don't have we cannot take keys away from these patients, okay? So it becomes very important. And in red here, it says physicians do not have the legal authority to withdraw a patient's driver's license, but we are obliged to report any unsafe driving to the authorities. I did have one patient that came in with their loved one, and the wife was telling the husband, you can't drive, you're not a good driver, you're making all these mistakes. He had a lot of overt HE. What happened was, look, husbands and wives, look, I'm married, I'm happily married. But when you argue, you don't want to listen to your loved one, right? They tell you something, you do the opposite, right? It's like, this is like standard, right? So, or, oh, I know what I'm doing, I'm fine, I'm a good driver, nothing, and he would get into minor little things. And so I had to tell him, I said, look, she's just looking out for you. The daughters were looking out for him. They don't want him driving and crashing, So we we can report it. And I told him, look, I can't take your keys away, but if you're having unsafe driving behavior, I'm going to have to let someone know. Of course, he stopped, and he's fine. So now he actually likes her driving him around everywhere. Take me here, take me there. And now it's interesting. So how do you manage these people? You advise patients not to drive 3 months after the last overt HE. Now, we can advise them, but that doesn't mean that they don't follow those directions. No evidence to support a driving ban to all patients with covert HE or overt HE without prior overt HE. You initiate or optimize HE treatment, avoid withdrawing or decreasing sedative medicines. Remember we talked about the benzodiazepine or the narcotics. Even if you don't have liver disease, right? They always tell you don't operate heavy machinery or do not drive when you're on narcotics. I'm sure a lot of people do though. Optimize treatment of comorbid disease, and you refer to authorities for formal testing for resuming driving privileges. So remember, advise patients not to drive 3 months after the last overt HE episode. What about my colleague Dr. Tapper looking at the impact of combination lactose rifaximin and GI consultation on post-discharge outcomes in patients with HE? Patients that were on rifaximin, which I don't know if it's showing up well in your in the slide there, but those are the ones in green versus the gastroenterology consult in blue. Those that got rifaximin did better in all aspects. So following HE discharge, in persons with greater than 1 year follow-up without HE, landmark analysis, which shows that rifaximin on these landmark studies were doing well, meaning less hospital readmissions, and then accounting for competing risks. So rifaximin did better than actually consulting your gastroenterologist. Hospital days after HE discharge, 30-day readmission after HE discharge, and hospital days greater than 1 year also did better in the rifaximin group compared to a gastroenterologist consult. Now, what about case study evaluations? Okay, let's look at patient 1, Henry. 52-year-old guy, cirrhosis, presented to the emergency room, has a lot of abdominal pain for the past 3 to 4 days. His wife said he's developed mental status changes accompanied by nausea and vomiting the last day. He denies having a sore throat, chest pain, or problems with myalgias and anosmia. So on exam, he reveals some shortness of breath and temperature of 99.6, not a fever. Testing reveals elevated liver tests. Patient demonstrates mild cough, but otherwise normal respiratory exam. His chest x-ray is unremarkable. Which of the following tests would be of little prognostic value in the patient's assessment? Ammonia levels, serum electrolytes, blood cultures, or PCR tests for COVID-19? Great. Most of you said ammonia levels, because remember, this is little prognostic value in patient's assessment. So ammonia, remember, it's a clinical diagnosis. It doesn't assess the patient's prognosis. Remember, serum electrolytes, if they have low sodium and potassium and you don't fix it, they can have poor outcomes. Blood cultures, if you don't catch something, they get infection, they can die, right? And then obviously with the COVID era, it had a cough and you worry about COVID. These patients are immunosuppressed in general because of their cirrhosis. Now, the next question, what is your next course of action for this patient? Do you want to provide supportive care for the unconscious patient? Do you want to identify and address all precipitants for HE? Initiate empiric HE therapy? Evaluate alternative cause of HE symptoms? Or all of the above? Okay, all of the above. I think that is the correct answer. I think the ones that were 7% just wanted to see their thing on the screen, right? I do that sometimes. It's like 1 or 2 of you maybe, just to see if it shows up. Yeah, that's good. But it is all of the above. All right, what about Gina? So patient 2, 68-year-old female, with a history of cirrhosis, recurrent overt HE, so she comes in a lot, presents with acute episode of HE. Patient lives with her daughter and son-in-law, who reports she has been sleeping more than usual over the past 2 days. She's stuporous and lethargic, and her response to questions are slow. She doesn't appear to know what day it is or where she is. The patient is currently being treated with lactulose. When asked about adherence and maintenance to therapy, her daughter responds that she's generally reluctant to change any eating-related behaviors and complains constantly about the GI side effects of lactulose. So once the current HE episode is resolved, what changes, if any, to the patient's prophylactic therapy would you recommend? Would you recommend no change? Would you adjust the patient's dose of lactulose? You want to prescribe the patient's rifaximin and add-on therapy as an add-on therapy, or prescribe PEG as an alternative? Okay, great. Prescribe rifaximin as add-on therapy. 78% of you said that. That's correct. Remember, this patient the reason you wouldn't adjust the patient's dose of lactulose is the patient was reluctant to take it because it doesn't like the side effect of lactulose, right? So the patient had a lot of overt HE, has come back to the hospital many times and was having confusion again. So has been hospitalized. So the additive therapy of rifaximin is the way to go. Obviously, they still need to be on lactulose therapy. Prior to leaving the hospital, the patient asks about restriction on driving. How long would you advise the patient to wait before driving again? Would it be 6 weeks, 2 months, 3 months, or 6 months? Okay, the majority of you got it correct, said 3 months, 78%. This was based on our Ishan recommendation when we looked at a lot of studies saying that 3 months, because remember, the most chance of these patients getting readmitted to the hospital can be anywhere from 1 month to 3 months, and that's why we recommend not to have them drive until 3 months after, until they're more stable. So to summarize about hepatic encephalopathy, it's a major complication of liver disease that represents substantial healthcare burden in the hospital setting and also to loved ones, right? They should be aware that patients with cirrhosis and COVID-19 may present with signs of HE and are at heightened risk for poor health outcomes, including death. Management goals include active treatment of the acute episodes, which you guys know, prevention of recurrence, which we talked about, and evaluations for surgical interventions. Several agents have shown good efficacy when administered as acute treatment or secondary prophylaxis. And following an acute episode of HE, prophylaxis, patient education, follow-up are essential to prevent these patients from coming back into the hospital and to have better healthcare outcomes. And so what I want you to take away from the clinical pearls are for patients with decompensated liver disease, obtain a thorough history of the mental status changes, rule out other causes of neurologic disturbances, and evaluate for the need of HE treatment. You want to utilize complementary strategies for ammonia reduction, supportive care, and nutritional support for the treatment of acute overt HE. Consider secondary prophylaxis, which we've talked about with lactulose and or rifaximin, depending if they've had a second episode of HE in patients with previous overt HE and higher risk for rehospitalizations. And then assess the nutrition of all patients with cirrhosis and encourage an individualized plan for maintaining adequate intake of calories, fiber, and micronutrients, as well as protein. And post-test polling questions. Should I go through that?
Go ahead, doctor.
Okay.
Thank you.
So John is a 45-year-old male who presents at the emergency room with disorientation, asterixis, and personality changes per observation from a relative who brought the patient in. On further exam, the patient was unable to correctly state the month, day, and week, but did know the appropriate location. Remember, they knew where they are. So which of the following grades in this patient according to the West Haven criteria? Grade 1, 2, 3, or 4? Okay, great. So I got I guess the point across. Most of you got it correct, grade 2 with the majority. Pre-test was 39% and post-test 68%. This is a hard question. That's why I was talking about knowing grade 2 and 3. Knowing where you are is sort of more of a grade 2. If they didn't know where they were, it would be grade 3. So it's a tough question, even for hepatologists. So according to Ishin, how long would you wait to add additional therapy to lactose for management of overt HE if there is inadequate response to lactose? Would you 8 hours, 16 hours, 24 hours, or 48 hours? Good, they were paying attention. So 24 hours, 54 in the pre-test and 93% post-test. So you would want to do this based on the guidelines. And which of the following therapies has been shown to improve outcomes and reduce hospitalization when used in combination with lactose for HE prophylaxis? Is it LOLA, PEG 3350 electrolyte solution, rifaximin, or zinc? Okay, good. Rifaximin is the correct answer. 84% pre-test got it right, and then 97% post-test. I think the ones that put PEG and zinc, you wanted to show that you made it on the list, but that's the incorrect answer. And I think that might be it. Let's see. Oh, no. Which of the following is among precipitants of HE in patients with cirrhosis that should be reviewed with patients at discharge? A low-protein diet, constipation, or joint pain? So what do you want to review with them at discharge? Great. Majority of you got it right. Constipation, 54% of it on the pretest and then 85% on the post-test. Got it correct. Remember, these patients have relative constipation, and you have to tell them if you take your lactose, you're supposed to have soft bowel movements to titrate to get rid of the toxins. And we are here for questions and answers. Hope you learned something.
Thank you. Actually, the low-protein diet is what you want, right?
Back in the day, they looked at high-protein diet, and they looked at that and said that, those studies in the past said avoid a high-protein diet. Mm-hmm. Now, most of the new studies, because it's a catabolic state, you don't care about really high protein anymore. In the past, you're right, they used to say do a low-protein diet, but these patients get really muscle-wasted, and now we know sarcopenia and muscle wasting actually precipitates more HE, so we want to bulk them up if we can.
So are you recommending high protein, or are you recommending just normal protein?
We recommend high protein because they'll never get there. So it's like you recommend high protein, and then they'll maybe get the 1.2 to 1.5 grams per kilogram, which let's say someone's 70 kilograms. I mean, it's very hard to have 80 grams of protein a day. So you recommend 100 grams of protein, and they'll be lucky to even get 70.
Yeah.
So.
All right, a couple questions here. One is, how do you treat fatty liver?
Oh, great question. That's fatty liver, it's really becoming an epidemic, believe it or not. So 40% of, at least you're in Texas now, so is overweight or obese. I'm actually overweight. You might not think so with this tailored suit, but basically overweight is defined as a BMI, above 25, and then obese is BMI of 30, right? Now you might have some bodybuilders that BMI is 37, but they're like, Arnold Schwarzenegger or whatever. Everyone that has fatty liver, we all have you have to have fat in the liver. What happens is there's a genetic component, but there's the environmental stimuli. Look at how good food has gone over the last 10, 12 years, 15 years. Back in the day, if you look at sports figures, they were all very skinny, athletic, but nowadays, you have to be bigger. Some of that is fat, like a lot of the football players. Now, when that happens, you have time on your hands, right? 20 years plus. Fatty liver disease is actually reversible, okay? The adage is like, diet, exercise, weight loss. Well, that doesn't help anyone because we all say that, and I tell myself that too, right? And it doesn't help me. So you really have to have a balance and go with what's best for that person. It should really be individualized. For example, with fatty liver, if someone, let's say, likes to eat certain desserts or certain things that are really bad for them, assuming they don't really have bad diabetes and they're sort of controlled, but the net calories are not causing them to exceed their calories to put on weight, that might be a more individualized diet. So really they need to get with a nutritionist to kind of manage that. Now, I recommend an app called MyFitnessPal. I don't get paid for saying it. It's a free app, okay? Because in my experience over the last 15 years doing this, that has been more helpful because patients can actually individualize what they like and they look at their calories, how much they want to lose per week, how much weight, and they can eat whatever they want. I know that's probably not the best thing to say because a lot of these patients have the metabolic syndrome, they have diabetes, they have high blood pressure. So I'm telling you from a liver side, I'm not attacking it from the endocrinology side. If they have diabetes, well, then they really can't eat all that stuff, right? So, because then their sugars are high, and then that leads to other problems. So the treatment really, the adage is diet, exercise, weight loss. But it's more detailed than that. I don't know if that really answered the question.
But when you said, let's carry this just a few steps further, is there a point in the liver when the liver, you said it's reversible, so yeah. Is there a point in the liver when fatty liver is not reversible?
Yes, great question. Once you get to cirrhosis. So there's 4 stages. I don't like how they named it. Stage 4 is considered cirrhosis, but what patients think is, stage 4, I'm going to die in 6 months. No, you can live 10, 20 years with cirrhosis, depending how early it is. Mostly 10 years before they have a lot of problems. Stage 1, 2, and 3, now we have non-invasive tests to check for that. We also have biomarkers, blood tests. It's not that accurate, but they're pretty accurate. We can do an ultrasound, a special elastography or fiber scan that tells you what stage you are. Stage 1, 2, or 3, it's all reversible. So up to the point of before cirrhosis, it's reversible. Now, if you get to early cirrhosis, you could technically reverse it, but by that time, it's pretty much too late. The reason is cirrhosis damages the foundation of your liver cells. The foundation, once your foundation is ruined, the liver cells can't regenerate. So yes, it's reversible. Like, that's why it takes about 20 years or so. It's more about
20
thinking,
years to reverse or 20 years
no, so 20 years to get to cirrhosis. So you have time on your hands. The problem is you see these patients all the time, let's just say, and it's year 5 and then year 10. Their habits for their last 20 years have been similar, right? They might be like 50s, 60s. And when you get older, it's very hard to change your habits. So you really need a lifestyle change because at that point, you're seeing them and they're getting worse and at a next stage, and they're not changing their lifestyle, which is the diet, exercise, weight loss, or controlling their diabetes, then they're going to progress. And if they're getting close to stage 3, I say, look, you're going to get to cirrhosis, and we're going to talk about transplant in a couple years. And so they really need to take it seriously, probably when they hit stage 2. But I'll give them leeway to, stage 1, 2, Thanksgiving's coming up, Christmas coming up. Remember, there's 365 days in a year. You can cheat for 90 days of those, It's the other, 8 months of the year that you kind of should try to be okay. And then if you have fatty liver disease, and if you have fibrosis of the liver, which is scarring of the liver, because you're on a path to get to cirrhosis. And so we have these discussions in my clinic, and then I help some people and some people I don't, I guess.
Let's also on this really quick. So these elastographies are relatively new.
Yes.
Relatively.
Yes.
How does one, as a general person, interpret? I mean, they give a score of like a KPA or something like that, right?
Correct.
So just tell people how do you interpret? You said stage 1, 2, 3, and 4. Is there a KPA that is aligned to stage 1, 2, 3, and 4? How do you interpret an elastography if they get an elastography at the patient's office or in the clinic?
Yeah, I think for primary care it might be hard to interpret. It's the GI or hepatologist that would have that machine in handy, or their radiology colleagues. So there is a KP associated. Now, let me separate FibroScan from elastography. They're two great tests, over 90% accurate, depending on how obese a patient is. If their BMI is above 35, it's less accurate because they have to go through a lot of fat. It's like Doppler when they look at the weather. Shoots radio waves, or I guess waves, goes to the liver. The harder your liver is, the higher the number. Now, that KPA ranges. We've had 2 elastographies in our clinic in the last 10 years. The older elastography, because of older technology, was different ranges. So it's sort of a difficult question to answer depending on which product they have. Like we have 2 different ones. One's GE and one's another one, right? So if I give you a generalization, please don't take this to the bank. Stage 1 would be between the 2, if I'm going to lump the FibroScan and elastography together, because remember they're 2 separate tests, I would give it a range of KPA of about 4.5 to 5.5, okay? The stage 2 is probably 5.6 to about 7.2. And of course, it depends on the person doing it, right? If they have experience and they're doing it correctly. Stage 3 is probably about 7.3, 7.5 to about 10.5. And then stage 4, cirrhosis, can be as low as 10.5, but usually it's greater than 12.5. But the problem is when you do that, and again, it's a non-invasive test. So if they're 10.5, that's the time I might say, look, I don't know if you're stage 3 or 4. I think we need a liver biopsy. This was a non-invasive test, but I need to know, is this going to change your outcome? If we do the biopsy later, that's when I get a biopsy, if they're about 10.5 or so, because I say, look, you might have cirrhosis. If you have cirrhosis, we have a whole different discussion. If you're right before cirrhosis, this is your come to Jesus talk, and you need to change your life now. You haven't changed it for 20 years. If you don't change it now, you're going to go down that path of cirrhosis, and that's okay if you get cirrhosis. We can help you, and you might not develop any problems for 5 years, but then you might have to think about transplant 10, 15 years down the line if you're a candidate. So I hope that answers your question.
And what's the difference between elastography and a FibroScan?
It's just different modalities.
But they do the same thing?
They do the same thing, yeah. A lot of GI practices have FibroScan. A lot of hepatologists have elastography. But their accuracy is between 85% and 95%.
One last question, then we'll call it a day. There's a question here about keto diet for liver disease patients. Do you recommend it or not?
Yeah, that's also a good question. It depends. Does that question specify, is it for fatty liver?
Do you recommend keto diet?
Okay.
So maybe you want to answer it both ways. Do you recommend it for fatty liver, or do you recommend it
let
for
me answer it
general
both
liver
ways.
disease?
So for fatty liver, I honestly don't care what diet they have. I don't like the word diet because you're already setting them up for failure. Like, you do whatever you want. MyFitnessPal, again, I don't get paid for saying it, but you can count your calories, you can see how much weight you want to use, whatever's you're successful to lose the weight. So keto for the fatty liver doesn't matter for me because they just have to be successfto lose weight. Less calories in, they lose weight. About 3,500 calories is a pound of fat, just so you guys know. So that means they have to take in 3,500 calories a month less, then by the end of the year they do 12 pounds. Fun fact, if you drank one soda, which is about 150 calories, you can drink diet, but if you drank one regular soda that has 150 calories and you don't replace it with any other thing that's 150 calories and you just stop that one soda, you lose 12 pounds a year. It's just a math problem. Because 150 calories, multiply that out, that's 12 pounds, which is kind of crazy.
That is crazy.
Yeah. I mean, but again, you don't supplement that, well, I'm going to eat a cookie today, or I'm going to drink another soda that's 120 calories. Right? So that's a fun fact. Now,
so you're saying 3,500 calories less a month is a pound less a month.
Yeah. So, or one less soda a day, or something equivalent to 150. A funny story, like,
well, what happens if an average person eats 2,000 calories, 1,800 to 2,000 calories? What if they just fast 2 days out of a month?
So you lose a lot of water weight in the beginning. So that's all water weight, and you'll put it back on right away. So,
But if you just don't eat for 2 days out of the 30 days a month, will that do the trick?
Yeah,
Because
I
you're
mean, that would
basically
be
down 3,500.
That would, yeah.
But you can't eat more the other days. That's
Exactly,
the trick.
that's the key. Because if they then say, oh, I fasted, and then you add on, let's say you get to 2,100 calories for the next 3 weeks, well, then you just added it all back by that extra 100 calories.
Yep.
That's why I think I love MyFitnessPal. Like the patients that have really used it, like they're very successful. I've even done it myself, and I've trained for half marathons. I could never make a full marathon, but I trained for half marathons and I lost a lot of weight, or I just did MyFitnessPal for 3 months and I lost more weight doing MyFitnessPal than training for a marathon. So 80% of it's diet. It's very crazy. And then to answer the question about the keto for just regular liver disease, I wouldn't recommend it per se. If you do it for a short period of time, it's okay. The reason is because the liver goes through ketogenesis, and when you starve your liver, it's not as healthy when you already have liver disease. Ketosis is really good when you have a keto diet for someone that is relatively healthy, but when you're already stressing your liver on top of liver disease, it's probably not the best situation. If you can be successful at it for a short period of time and do it, then that's fine, but I would not do it long term.
All right. Well, I will end it with this last question that said, this has been a great conference. I enjoyed each speaker and also the panel discussion. So we enjoyed you all. Thank you for coming. I hope this was very useful for you. Again, I'll circle around and say, really, we should be, all of us should be clapping for you because you guys gave up your Saturday morning and early afternoon to get yourself educated, which is only going to help your patients and your system. So we applaud you for doing that and wish you the best, and thank you for joining us.
Yep, thank you. Awesome.